Hello, good evening everyone and welcome to the Eurogen webinar series. Just before we get started, I would like to take a couple of minutes just to mention a few words about the European Reference Network. Eurogen is one of 24 European reference networks that were created in 2017 by the European Commission, and they're also funded by them. And they all treat patients with rare diseases or complex conditions that require highly specialised healthcare. So they cover all the different medical domains. And all the European reference networks aim to deliver quicker specialist evaluation and care for those patients with the rare or complex needs. And some of our activities, well, we're a network that deals with highly specialised surgery, and one of our activities is virtual consultations. We have a clinical patient management system which allows the secure discussion of the complex cases. So it's the advice from the network that travels, not the patients. And any healthcare provider working in any country in the EU can request advice from the ERN network of experts. So please don't hesitate to do that. And it's free. The advice is there and it's willing to be given. So please take us up on that. We also collaborate on education and training activities like this webinar programme, and we also have an ERN exchange programme where any members of the MDT can travel to other healthcare providers and look at how they're doing the surgeries or delivering the care in those other high volume centres. We are also creating a Eurogen patient registry, which is just begun to be operational. So we hope that this will be a very important evidence base for research going forward, because as we all know, one of the main problems is a lack of data for patients with rare diseases and complex conditions. So that's a bit about the ERN, and this evening, in collaboration with another ERN, Ernica, who we work with closely, and also the Anorectal Malformation Consortium, we've collaborated to bring you this webinar this evening on Hirschsprung's disease and the basic principles of pathology. So I'm really delighted to welcome this evening. We have Dr. Roxana Rassouli Kirchheimer, and she's from the Amelia Children's Hospital in Nijmegen, and that's part of Radboud University Medical Center in the Netherlands. And we also have Dr. Thomas Mentor from the Institute of Medical Genetics and Pathology at the University Hospital in Basel, Switzerland. So Thomas trained in surgical pathology since 2019, and he's been working in the field of paediatric pathology. And Roxana trained as a paediatric surgeon, and she's specialised in colorectal surgery. So without further ado, thank you both for sharing your expertise here with us this evening, and please do feel free to ask questions at the end. Roxana, you have the floor.
Thank you very much, Michelle, for your introduction. The first part of our webinar will be about technical issues when you take a biopsy. And since I will show you a couple of instruments, for me it is very important to point at the fact that I have no conflict of interest. And the first part will be about how we take a biopsy as an outpatient clinic procedure. So the patient is under no anesthesia. As you can see, we use a laparoscopic 5mm instrument, which also can be used, for example, by our orthopedics, which is also used by our orthopedics in order to take biopsies from the knee if they take a biopsy. So these instruments can be shared with other surgeons. So anyway, we use this instrument in order to take a biopsy, and as you can see, we introduce the instrument by bringing it into the anal canal, making sure that we enter the anal canal at least 2 to 3 centimeters from the skin to make sure that we will not biopsy the anal channel. And as you can see on the third page, the first thing you usually biopsy is a lot of stool. You take your time and then you try again. And if you are patient enough, you can finally see at the end of, at the tip of our instrument that we managed to take a biopsy. And during outpatient clinic, we usually try to take 2 biopsies. And if you in your institute take a biopsy with a suction biopsy instrument, that is fine, but we had a couple of issues with them. Next to the fact that they are quite expensive, we had some difficulties to taking out the specimen out from the tip of the suction biopsy instrument. We sometimes really had to squeeze it, and our pathologist had problems with really making a proper diagnosis. And this is why we came back and used this instrument. If the biopsy, if the specimen is too small and cannot be analyzed by our pathologist, we repeat this procedure or we take the patient to the OR. And in the OR, again, one key element is that you have to make sure that you will not take a biopsy from the anal canal. You can use either retractors in order to make sure that you will take the biopsy at the right side, or you can use a ring with pins, and you can see here the dentate line, and then you can hide the dentate line, and 1 up to 2 centimeters proximal from the dentate line, you take a biopsy, again making sure that you will not take a biopsy from the anal channel. And especially when the patient is in the OR, we make sure that we have at least 2 to 3 biopsies to make it as easy as possible for our pathologist to make the right diagnosis. And at the beginning of your surgical procedure, whatever plans you have, transanal pull-through as we do it, or Duhamel, you definitely should take again a biopsy to make sure that you will take out the affected part, and you will really leave behind a ganglionic bowel. So at the beginning of our transanal pull-through, we make a subumbilical incision, as you can see here in the first picture. Then we bring in transanally a Hagar. You can feel with your fingers in the abdomen where your Hagar is. And what we sometimes do because of a distended rectosigmoid is we mark it. So proximal would be a long suture and distal would be a small suture, especially because when you start taking a biopsy and then start making a further dissection, you want to make sure that you go towards the right direction. In order to take out the bowel, it's easier to pull out the larger Hagar and to bring in a smaller one. And as soon as you bring a smaller one, it will be possible to take out the affected bowel through the subumbilical incision, as you can see here on the left picture. Where you see the forceps, this is the so-called transitional zone. And our colleague, Dr. Thomas Mentor, will have a talk about that one too. And then when you see here the transitional zone, you have to make sure that you will not take a biopsy from there, but at least 5 to 10 centimeters proximally. At the same time, you can also check the place where the site where you would take your biopsy, whether if you even go a little bit further proximal, it will be possible to pull through the part you want to pull through. Then you can take a full thickness biopsy, which is very important to make sure that you will not pull through the transitional zone. When you take the biopsy, you should also make sure that the scissors are really perpendicular to the colon, because as soon as you want to take a more diamond-shaped biopsy, the specimen could have squeezed submucosal tissue or even not enough submucosal tissue for our pathologist to make a proper diagnosis. So it's very important to really hold the scissors perpendicular and to take a full thickness biopsy. Then you can close this side. And what we do is, after we have heard that we have now good healthy bowel, we start dissecting the bowel all the way to the small pelvis, and we use a handheld device with a bended jaw so that we can really make a dissection all the way to the small bowel, and then we take out afterwards with our transendorectal pull-through the aganglionic bowel, and that specimen will be sent to our pathologist. And by that, I would like to ask Thomas to give his talk about pathology. Thank you very much for listening.
Yeah, thank you very much, Roxana, for the kind introduction. And I'm also happy that I have now the possibility here to share the experience here from Basel with you, and can tell you how we work on the biopsies of Hirschsprung disease. So I hope now, sorry, now you can see my screen. That should be fine. So there's no conflict of interest, I can declare. And this is just a short cut of the agenda, what we will go through today. So we'll briefly touch on the histology of the gut. I'll also talk, of course, on the innervation of the gut, leading us to the pathophysiology of Hirschsprung disease. So kind of why does this disease develop? And then, of course, the main topic is the morphology of Hirschsprung disease. So what does the pathologist actually need to see so he can make the diagnosis of Hirschsprung disease? And I'll also tell you about our approach, where we use enzyme histochemistry for analyzing our specimens. And of course, I'll also show you several illustrative cases of both Hirschsprung and non-Hirschsprung diseases to show you the broad spectrum of potential differential diagnosis in the setting of chronic obstipation. What you see here on the right is a frozen block of an anal pull-through surgery specimen. So you see here it's kind of rolled up, and this is used, of course, to save slides, and also to make it more easy, kind of to see how long is the aganglionic zone, how long is the transition zone. So this way, if you roll up your specimen, this is much easier to be done. What you see here on the right is a gut specimen from an autopsy of a fetus of the 15th week of gestation, and you see already at that time we see the nicely developed plexus muscularis, plexus myentericus, you see here. And you have to remember that, of course, in going back to histology, there are 4 different layers of the gut. You have the tunica mucosa, the talar submucosa, where we find the plexus submucosus, which of course is important when looking at the suction biopsies Roxana talked to you before. Then here we've got the tunica muscularis propria with a more easily to appreciate plexus myentericus, and of course we also have the very tiny, at least at that developmental age, very tiny tunica adventitia. And of course, this now also depends on what kind of biopsy you're taking. So if you are taking kind of the initial diagnostic biopsies, then it is important for us that we already also receive a good batch of the talar submucosa, because the ganglion cells are there. And this is finally what we need to rule out or to confirm the diagnosis of Hirschsprung disease. When we are talking about the setting of intraoperative frozen section, as Roxana also told you, then it is much easier, and I'll show you an interesting case, an illustrative case afterwards, that we get a specimen of the plexus myentericus, because this is much more easy to evaluate. Here again, you see the nicely already developed plexus myentericus at the gestational age of 15 weeks. So how is the gut innervated? So there is a migration of neural cells already early in embryogenesis from oral to aperal. And that migration is completed by the end of the 12th week of gestation. So by that time, the neurons should have reached the rectum area. In case this migration can't be completed, then we have the pathologic features of Hirschsprung disease, and this is also shown here in this graph. So you see here how the nerve cells migrate along the gut. So first they populate the space of the plexus myentericus, and from there they migrate into the plexus submucosus. And you see, in case this for some reason does not work, then you have here the shorter or longer ganglionic segment. Innervation of the gut is very complex, and you see here in this graph from a very good recently published book on Hirschsprung disease and allied disorders, which can only show many of the differential diagnoses and also give you insights into the pathophysiology of the disease, how complex the gut nerve system is. I think every one of us knows the saying of the brain in the second brain we have in the gut, and I think if you see how many different types of neurons can be found here, I think these can well be explained. Of course, for us in routine diagnostics, so this is maybe more interesting for anatomists. So here we just look at the motor neurons and not of all the other different types of neurons you can find here in this space. But this graph, I think, nicely shows you the complexity of the innervation of the gut. And this is, of course, needed that the gut can coordinate the peristaltic wave to move to have the movements of the gut, so to achieve its what it's there for. And it has to be remembered that there is a presence of both intrinsic and extrinsic impulses. So both it's kind of an autonomous network, but there's also influence from outside. So this is mainly, of course, the parasympathetic and the sympathetic nerve system, and especially the parasympathetic nerve system is of vital importance also for the development of Hirschsprung disease. This is now what we will talk about in the next few minutes. So on the one hand, of course, due to the lack of neurons which can propagate the peristaltic wave, we have a problem. So it's kind of that the feces gets stuck somewhere in the gut. This then finally also leads to missing modulation of the parasympathetic innervation of this ganglionic segment, and this is also then what finally we use for the diagnosis when we perform enzyme histochemistry. And clinically, if we have this increased cholinergic innervation, we see a spasm of the smooth musculature leading to bowel contraction. And I think this is also kind of the pathognomonic finding you see when you do rectal contrast X-ray or something, which shows you this part of the contracted bowel, which is then the correlate of the ganglionic segment. This sketch again shows you the complex innervation of the gut, and if you look here on the left, you have the motor neurons here, which kind of modulate also the parasympathetic innervation. And if the motor neurons are missing, which is here, then of course you have a lack in this modulation, which finally then leads these parasympathetic ganglion to kind of increase the branching of their nerve fibers, and this is finally what we will also see in Hirschsprung disease. Hirschsprung is a complex field. I think all of you have heard of the RET mutations, but as you can see here, the migration of the neurons is a very complex. It's very complex, and this also shows you that there are many other genes and proteins involved in this. And I think as more and more genetically cases are genetically worked up, we learn more and more about the complex interaction of what is finally happening in Hirschsprung disease. So just this should remind you what we are dealing here with, this very complex network of different proteins and signal cascades involved in the migration of the neurons. So what do I as a pathologist finally see if I look at resection or a suction biopsy? So of course, what I don't see are the neurons of the plexus submucosus and plexus myentericus. Because it's always, for a pathologist, as you know, it's always difficult to prove something is not there. It's much easier for us to say, okay, Here we have cancer cells, here we have neurons, and if you don't see anything, this is always a bit difficult to prove, and we feel a bit awkward because you always have the feeling, oh, am I missing something? Is the biopsy really representative? And therefore, I'm very happy that we also have kind of a positive finding in the Hirschsprung disease, and which is the increased activity of the acetylcholinesterase in the parasympathetic nerve fibers. What we can also see, and I'll show you an example of this in a few minutes, are hypertrophic nerve bundles, also of this parasympathetic system. And what we can see is kind of secondary changes, but this is something very unspecific, which you can also see in cases of long-standing chronic obstipation due to other causes, which is lymphofollicular hyperplasia and the thickened lamina muscularis mucosae. So, as you know, worldwide there are of course different approaches to diagnosing Hirschsprung disease. So can you just do it based on the H&E? Can you do it by using immunohistochemistry for specific markers like carotinin or other markers for neuronal cells? Or can you, and the other approach is then enzyme histochemistry. And of course, you can ask yourself, well, now in the 21st century, do I still need a technique dating back to the 60s? And this is a photograph I also show when I'm talking about another special field of mine, which is electron microscopy. And there, of course, we've got the same discussion. So, well, do you need a technique developed already in the 1930s still now for making European diagnostics? And I would say I'm a big advocate of both electron microscopy and enzyme histochemistry, because I think it's really helpful, especially to have this kind of positive finding in your biopsy, which reassures you that you have the combination of absence of neurons and the hyperactivity of the parasympathetic nerve system, which then allows you to make a confident diagnosis, especially if you only have a very tiny biopsy. This is now what it looks like if we do the biopsy. So normally our surgeons take 3 biopsies at 1, 2, and 4 centimeters of the linea dentata. This is then how it's cut up here. So the tissue is cut up line-wise from one slide to the next one. So you see here, first I start here, then here, 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 and here. And it's the second line, where then the tissue is cut best. So it's very perpendicular cut, so you can really nicely see the mucosa and the talar submucosa. So we normally do further staining for the acetylcholinesterase without counter staining, because that is of course much easier to see the nerve fibers. We also do acetylcholinesterase with a counter staining, which then of course allows you better to appreciate the morphology of what actually you have in your biopsy. This of course is especially important if you're dealing with tiny biopsies, where you have to ask yourself, is that tissue really representative for what I'm looking for? So is there sufficient talar submucosa so I can find some ganglion cells? And then what we also do is performing stainings for 3 dehydrogenases, LDH, SDH, and NOS. And what we also do, just to get a better appreciation of the morphology, is a serious red stain, which can also show you like what kind of tissue you have. Is there already extensive fibrosis? In that way, this also is quite helpful. So how does enzyme histochemistry work? And as I told you, this is a technique already developed here. And we had a big advocate here in Basel, Professor Meyer Ruge, who developed the technique already in the 70s. And the idea is that on the one hand, we want to see neurons when we look in our sections. And of course, what the other advantage is, and this is only possible using enzyme histochemistry, is to look at the activity of the parasympathetic nervous system. This I already told you. So these 4 stainings we are using for our for making the diagnosis, and this is now a staining sample for the LDH. You can nicely see here you've got the mucosa, you've got the thickened lamina muscularis mucosa, and here you can find the ganglion cells. Normally in a submucosal ganglion you shouldn't have more than 8 of these cells, so here you've got 5, so this is fine. And seeing that, this already rules out Hirschsprung disease, of course, depending on where the biopsy was taken. So whether it really is a very distal biopsy, this of course is also necessary that the clinicians tells us where exactly he took the biopsy from, but we'll hear from that also later when I come to my illustrative cases. There are, of course, also some pitfalls in enzyme histochemistry, and here in Basel now we've got an experience of almost 60 years with that technique, and there we could see that it's important that your sections are too thin, because this then leaves too little tissue so that the enzyme histochemistry can work. So this is a nice example of that. So here on the upper part, you see kind of a classical Hirschsprung with all these little nerve fibers. But if of the same tissue you have a very thin section, it becomes much more difficult. So for example, all these thickened nerves here in the talar submucosa, they somehow disappear here. And I think making a clear-cut diagnosis of Hirschsprung disease in that case is really very tricky. And yeah, this is a problem. Of course, it's also important that you stick to your protocols, so to leave enough time for the reactions to work in order to avoid falsely negative results. And it's also important, of course, as we need fresh tissue, that you have adequate tissue preservation, so it's really sent on dry ice to your lab if it's kind of an external case, in order to avoid autolysis of the tissue, which of course then directly affects these enzymes you're looking for in these staining techniques. So why do we need 3 oxygenases? You can say, okay, if I do LGAs, that's fine. We perform it as a kind of backup in case we experience some staining difficulties, or we have some problems with the chemistry behind it. Of course, the more you see, the more confident you might be, especially if you have very tiny biopsies. And then if you have these additional step sections of the tissue, this can then help you to really confidently say, okay, I have looked at 50 step sections in 3 different oxygenases, and there's no neuron. And then, yeah, I think also the clinician is more confident. And there's also another advantage, and this is then a comparison of the SDH and the NOS stain, which you see here. And then here in the SDH stain, it's really, here we see the plexus mesentericus. It's really very difficult to appreciate the neurons. In the NOS stain, that's kind of clear cut. And this shows you that in this patient with the reduced expression of SDH, you can postulate here we have a kind of immaturity of the nerve system, and of course this could then also explain why the patient, especially if it's a very small child, is suffering from chronic obstipation. And in these cases, of course, it can be discussed whether you just have a wait and see approach without surgery being performed, because there's still a chance that there will be a maturation of the enteric nervous system. Of course, I know that technique is there's a huge discussion of whether really you need that. Some say outdated technique, but I think I'll just sum up the potential disadvantages, and I think this is something you can also then discuss with your pathologist at their labs, on whether you can perform that technique or not, or whether it might also be debatable whether you decide, okay, if I want to stick to that technique, then I try to send my samples to other centers. So here, like here in Basel, we receive specimens from several German, Swiss, and Austrian hospitals, and they just send it in a box of dry ice. And then after 1 or 2 days, the sample arrives here, and then we can make our diagnosis. So of course, one issue is that, as many pathologists, and maybe you also know, when you're doing frozen sections, the morphology in the cryomaterial is a bit more difficult to evaluate in comparison to FFPE tissue, where it's paraffin embedded. Of course, it's also difficult as we use most of the tissue, especially of the small biopsies, for the Hirschsprung diagnostics. There's mostly no tissue left, so it's difficult like to perform other stainings, like for inflammatory cells. Handling might, of course, be costly if you have to send your specimens a long way or even abroad, and then you get into difficulties with customs or whatever. And of course, it's also important that in your lab you have some people who are trained in the technique. You need all the reagents, and of course, this means that you need to have some a certain amount of specimens to be analyzed, so that kind of your financial department allows you to maintain this technique. But now I'll try to show you the beauty of these stainings, and we will start with a classical case. So this is a male newborn presenting with intestinal obstruction on the first day of life. We also unfortunately presented with a volvulus of the ileum and a perforation, and this is also very typical, especially for the findings we see here, is that the patient had a positive family history for Morbus Hirschsprung. So both mother and his older sister were affected by the disease. And what you can see now here, I hope this is working and not taking too much time, is this Swiss roll you saw on my first slide. So where we take about 15 centimeters of rectum and roll it from the distal to the proximal part. And here you see then an H&E stain. And what we can appreciate from here is very classical finding of the chronic obstipation, this prominent lymphofollicular hyperplasia, which goes all through the specimen. Now, of course, most interesting for us is the acetylcholinesterase. And remember, the most distal part of the rectum is now in the inner part, and this is something I can show you here. And here we nicely see the increased network of nerve fibers here in the mucosa. So here you see the crypts, and between you see like these tree-like protrusions of the nerve fibers. We also see an increased parasympathetic activity here, these nerve fibers in the lamina muscularis mucosa, and very classically, you also see the thickened nerve fibers in the talar submucosa. And remember, normally if you take the biopsy for the diagnosis, you mostly end up here. And of course, this shows you that, of course, the bigger nerves might be missed. What you also can see here is the increased activity here in the tunica muscularis propria. When we now look at the LDH staining, so we can see that there are no ganglion cells, not in the plexus submucosus, and also not here in the plexus myentericus. So this is just some fibrotic tissue, but there are no ganglion cells. When we now look further upwards in the colon transversum, so here we see suddenly, if you look here again at the mucosa, just see if I can show it you in the best way, like here. So I appreciate it's a bit difficult to see, but here you have some crypts. Here you've got the talar submucosa, sorry. And here you've got the tunica muscularis propria. And now what we see, if we look at the mucosa, we see the network of these little nerve fibers is gone. And this is another potential pitfall. So if you take, if for some reason, of course, the patient presents with an acute ileus and you think, okay, could it be Hirschsprung? And then you just take your biopsy, like in the colon transversum or colon ascendens. These are areas where you don't have this increased parasympathetic innervation anymore. And this can then, if you do the acetylcholinesterase staining, lead to a false negative result, because here you physiologically, also in long Hirschsprung disease, you wouldn't see the parasympathetic innervation. This is only seen in the rectum and in the lower part of the sigma. So this is really important for you to remember. Now I'd like to share with you a case of a so-called ultra-short Hirschsprung. This is defined as the presence of ganglion cells at least 3 centimeters up ano. So you have a very short aganglionic segment, and these then are patients where, of course, surgery might not be the primary options, but some patients also do very well with Botox injections. But I think Roxana can tell you more about the treatment of these patients than I can. This case was especially interesting because I received this as a consultant case, and they, for what reason ever, only performed for the biopsy at 1 centimeter up ano. They embedded this material in and fixed it in formalin and performed FFPE workup. And only in the biopsy at 3 centimeter, we then got the enzyme histochemistry. And this shows you now again the problem you have. If you look at an this is the H&E stain here at 1 centimeter up ano. We see the mucosa. We see a kind of fibrosed talar submucosa. And what is quite striking in this case is that you have again these thick nerve fibers. And maybe you can agree that, of course, it is very tricky just based on the H&E to look for neurons. You really need a lot of experience, and this, I think, is much easier than if you do the enzyme histochemistry. What is helpful in this case was that we also performed the staining for GLUT1, and this nicely showed us the perineuron of these nerve fibers, and this then confirmed our diagnosis. Okay, this is also quite typical for ultrashort Hirschsprung, and as you can see on the, so this is stain for nerve fibers, and here again you see we had some artifact problems in this tissue, but at least we didn't see any clear-cut brown dot here. So confirming the diagnosis of an aganglionic segment at 1 centimeter. But then when we looked at the biopsy at 3 centimeter, we saw some ganglion cells, so confirming our diagnosis of ultrashort Hirschsprung. And quite typically for the ultrashort Hirschsprung, you have these thick nerve fibers and an increased parasympathetic activity in the lamina muscularis mucosae. And classically, you don't see these parasympathetic nerve fibers between the crypts. So this is another case a patient who had been treated with the surgery 8 years before we saw the biopsy. Now he returned to the physicians with encopresis. And now here we see a biopsy taken at 3 centimeters, so 8 years after anal pull-through. And then if you look here in this biopsy, let's show to the higher to lower magnification, you can appreciate where we are. So here we see the mucosa, and here we see the lamina muscularis mucosa and the talar submucosa. And if you go closer, you see we still have an increased nerve fiber activity here in the neorectum and also in the lamina muscularis mucosa. And when looking at the LDH stain, we couldn't identify. You see how many step sections you have to evaluate. That really takes up to half an hour to go through that case. And also you see that depending on which line you are in, it's easier or more tricky to evaluate the specimen. As here, this is kind of still a very tangential cutting. So here you basically don't see any talar submucosa. In this row, it's better. And in the upper row, it's really perfect. So this is the kind of biopsy I like to look at because it's very easy to see where we are. As you see, no nerves, and this shows us that the patient maybe had a very short remaining aganglionic segment after surgery. And of course, in the course of the years, that part again grew again for some centimeters. Now the question is, of course, then how to treat this patient. But this is also, in a few minutes, we'll touch upon the issue of the frozen section. This is really sometimes tricky to say, could this still be the transition zone, or are we already in the well-developed part? So I think I will skip this case and we'll go to the frozen section. And this is something I can show you here. So this is, as Roxana told you, you should take a biopsy of the whole gut wall. So because this makes it much easier for us to see the normally regularly distributed ganglion cells of the plexus myentericus. And you see here, there's nothing. So here we still are in the aganglionic segment. Here, that's an H&E, and I think, again, at least for me, as I'm not so experienced with just looking at the H&Es, it's really difficult to say, okay, is this now really a neuron, or could this just be some kind of, some connective tissue we see here in the area where the plexus normally is located, or some kind of hypertrophic nerve fibers. In the LDH, then you nicely see the cytoplasm of your neural cells. And then finally, if we have left the transition zone and are in the normally populated gut, you nicely see here one plexus, one ganglion plexus after the other. So this is how they should be, like beads of pearls. And then you can be confident, okay, now the surgeon is safe and it should work well. For the last minutes, I'd like to share with you some cases where we could find a differential diagnosis to Morbus Hirschsprung. So here we are dealing with a 13-year-old boy who presented with a megasigmoid, and Morbus Hirschsprung had been included by the typical rectum biopsies. And then they thought, was there some problem with the anastomosis, because they of course had to resect the megasigmoid, and the anastomosis was resected. This is the specimen we then saw. So here you see again also rolled up like before, so we get a better overview of the tissue. Then if we look closer here in the lamina, in the tunica muscularis propria, we see the smooth muscle fibers, but what we also see is kind of a focally dense interstitial infiltrate. So all these cells normally shouldn't be there. Normally there should be just some small vessels and the smooth muscles. Looking closer, we also could see eosinophils. I highlighted them for you. Again, here we see several eosinophils. And also, if we look now in the plexus mesentericus, we see on the one hand there is some kind of uneven distribution of the ganglions of the nerve cells. You see here's a larger cluster, then here's a smaller one, and then here somehow it's difficult to appreciate, okay, where does the plexus continue? And also here we see only 2 cells. And what we also see here, we see very many other small cells. And if you look at it by immunohistochemistry, you see these are CD8 positive lymphocytes. So you can make the diagnosis of a CD8 cytotoxic T cells mediated ganglionitis. When making our staining for nerve cells, here we mainly use the antibody MAP2. You can also nicely see the irregular configuration of the plexus mesentericus. So you see here there's a very large ganglion, then here somehow everything disappears, and it's also difficult to appreciate the normal architecture, and then here it comes again. So this shows us that in this case we could diagnose a lymphohistiocytic and eosinophilic inflammatory infiltrate of the tunica muscularis propria and ganglionitis. We already saw a reduced plexus mesentericus, and of course we also saw the architectural changes, which then go in hand with an incomplete desmosis. But here the underlying disease was the ganglionitis, so the destruction of the nerve cells of the plexus mesentericus is a kind of autoimmune disease in most instances. And there are of course also many cases where you can also look for typical autoantibodies. I'd like to conclude with a case of a 2-year-old girl who presented with acute abdomen and suspicion of Hirschsprung disease. So as you know, not all children with Hirschsprung disease present at birth. So and what we can see here in these resections, we see again the mucosa, and we see the tunica muscularis propria, which somehow seems very densely populated. And if we look closer, we again see a dense inflammatory infiltrate, so much more than in the previous resection. And we again can already, from the medium magnification, appreciate many eosinophil granulocytes. So this is a case of leiomyositis, and you can also see here that in contrast to the previous case, there is already an extensive loss of the smooth muscle cells, which have been killed by this autoreactive infiltrate. Again shown here in the high magnification, so you see all over here, the cells have shrunken or they have completely disappeared. So they have been attacked by the immune system. And of course, we also see that here in the plexus cells, but here as the focus of the inflammatory infiltrate is lying in the smooth musculature, so it's rather possible that of course this is kind of a bystander of the dense inflammatory infiltrate. Here illustrated by a stain for T cells, and here as you see most of the T cells are cytotoxic T cells. This is now a case of T cell mediated acute leiomyositis, which is well documented in children. It has viral infection as a potential trigger, and this was also possible in this case where adenovirus DNA could be found. So now I'd like to sum up. What should you take with you from my talk? So remember, Hirschsprung disease can be reliably diagnosed histologically if, and it's very important as Roxana also showed you, adequate biopsy material is available. I hope I could convince you of the advantages of enzyme histochemistry, especially to allow to analyze the parasympathetic activity. So you also have a positive finding in your biopsy, and you cannot only report the absence of the ganglion cells. And of course, it's also important both for you and the pathologist to consider potential differential diagnosis to Hirschsprung disease. With that, I'd like to close, and I think Roxana and I are both happy to take your questions. Roxana, we can't hear you.
Sorry. Thank you very much, Thomas. It was a great talk. It's always a pleasure to listen to you. Very nice. Even for me as a surgeon, I understand everything. Thank you very much. So we have one question about how we should take the biopsy. And the question is actually a good one. How do you know that if you take the biopsy, the rectal biopsy, that you are deep enough? And have we seen any risks of bleeding? So that's really an excellent question. I don't know whether you remember, we were talking about we used to use the suction biopsy and that we had a couple of problems. And one problem was definitely prolonged bleeding. They stopped usually by themselves, so you do not have any surgical procedures to do. But that was really one of the reasons why we started again using that laparoscopic instrument, because with that we do not see prolonged bleedings. We had recently one patient who had a little bit of a bleeding 10 minutes after taking the biopsy, and then it stopped by itself. So we do not see large bleedings. And the other thing is, if you have looked at the pictures Thomas showed us, he wrote that from the skin level, at least 3 centimeters above, in a 5-year-old patient, you're sure that you're not making a biopsy in the inner channel. So this is why in a baby, we mark the tip of the instrument at about approximately 2.5 centimeters. And how do we mark it? Very easy, as we surgeons sometimes are. We just put the finger 2.5 centimeters. We bring the instrument in and then we take a biopsy. So we make sure that we will not make take a wrong biopsy from the anal channel, but be really in the rectum to make the biopsy. I hope with that I answered the question. Do we see any more questions?
Well, it seems we have been pretty clear.
I think this is a question for you, Thomas.
Okay.
Thank you very much. Okay, I forgot my glasses. This is a problem for me now, Luce. Yes.
Yes. Thank you very much for these presentations. Do you have looked about false negatives in your cohort with this technique of biopsy?
Well, I think, well, you know, so you want to say something, Roxana?
No, go.
Okay,
go
so
for it.
I think our problem with the false negative cases mainly is then if you don't have sufficient material. So if you have got a very tiny bit of the talar submucosa, then of course always, you know, you sometimes don't feel confident that to say, okay, I see I'm in an aganglionic segment, and then of course in other cases, if you say, okay, did my enzyme histochemistry really work well? So preservation of the tissue as mentioned, then I think what you should do, you really should be very cautious, or explain the surgeon, okay, you sent me a sample, but well, I am not 100% sure that it's Hirschsprung or not. And then I think the best way, as Roxana said, is to really do another biopsy. But yeah, so systematically, we didn't look really how many false negative or false positive cases we had, but it's always our strategy to be quite cautious in making the diagnosis if we are not sure, because I think it's a less problem for the patient to do another biopsy than to do a pull through.
I totally agree with what you're saying, Thomas. So what we do is, if the specimen is not big enough, the pathologist will definitely tell us. And then it depends. If the patient is doing well, we take another biopsy as an outpatient clinic procedure, because the advantage of that procedure is we do not need any anesthesiology. If we are in doubt and we need a quick answer, then we prefer going to the ER and making sure that we take a proper biopsy where we definitely know that the pathologist will receive enough tissue to make a good diagnosis.
Yeah. I also remember a case earlier this year where they did 4 biopsies and all 4 biopsies only consisted of feces. So then of course the the surgeon was very disappointed. Said, that can't be, you know. And then he said, okay, there's some tissue left of the specimen. Then we cut through everything and still there was nothing. And then they repeated the biopsy and then we could make a diagnosis of presence of ganglion cells. So it's really, as a pathologist, you shouldn't be too confident making a Hirschsprung diagnosis because of the severe consequences, you know, for the clinicians that has.
So again, I told you real-time pictures, and it's very common that when you bring in the instrument at first, the first thing you will get out of the anal canal is feces. That's very normal, especially in a patient who has Hirschsprung's disease. We all know that it will really just be like in the Olympics coming out the defecation. So that is quite normal. The good thing about when you do it with an instrument, we use it, you can see right away that's feces. When we used the suction biopsy, it was very, very difficult to see whether it's a real biopsy or only feces, and then the pathologist had to tell us.
Yeah, especially if you say so, like in the one case I told you about, the clinician told me, you know, it was bleeding, so we thought we were in the right depth, but nevertheless, yeah, it was really 4 times negative.
Any more questions? Thank you very much, Thomas. Thank you very much, everybody,
for the kind invitation. Yeah.
Thank you.
Okay.
Have a great evening, everybody. Bye-bye.
Bye.
Goodbye.